Welcome to today's webinar. My name is Russ Round. I'm the Director of Marketing at Osteogenics. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we'll try to get them answered during the webinar. At the end of the webinar, you'll receive an email with a feedback survey. Once you complete that survey, an email with your CE certificate will be sent to you. So be on the lookout for that email shortly after we end today. So it's my pleasure to introduce tonight's speaker, good friend of the company, good friend of mine. Really excited to have Dr. George Kotsakis with us tonight. Dr. Kotsakis is a board-certified periodontist and a fellow of the ITI. He received his DDS degree from the University of Athens, and after graduation, he practiced in Athens prior to coming to the U.S. He then completed his residency in periodontics and MS in science at the University of Minnesota, where he first got involved in periimplantitis research. Following his training, he became an assistant professor in the Department of Periodontics at the University of Washington in Seattle. He then went on to be an associate professor at UT San Antonio and is currently a professor of oral biology and assistant dean for clinical research at Rutgers School of Dental Medicine. Dr. Kotsakis has published over 100 peer-reviewed scientific articles and textbook chapters with nearly 30,000 citations of his work. Additionally, he serves as associate editor for the Journal of Periodontology, the Journal of Clinical Implant Dentistry, and related research. He lectures frequently and gives hands-on courses both nationally and internationally on periimplantitis therapy. With that, I'm going to turn it over to George. Thank you, Dr. Kotsakis, for being here.
It's a great pleasure to be here, Russ. You know, as I'm growing older, I realize I have to cut things out of my CV. But thanks for inviting me. It's always exciting because we've been on a journey together, periimplantitis, for many years, and finally culminated into some things that we can get out to the world. And we're at a point today, where in periimplantitis we can give evidence-based clinical recommendations, and that's, leaps forward from where we were 5 years ago. So this is a little bit of my background, my disclosures, and this is part of the teams that I've been glad to be a part of. This is my current team at Rutgers University at the School of Dental Medicine, and in previous teams, and it's really been a team effort to unravel what happens in periimplantitis, and a very humbling experience. Also, I'm very glad to be part of the PICOS Institute, where we're now launching a full-on periimplantitis CE course curriculum, and I'm very excited about that as well. So moving forward, whenever we do surgical implant dentistry, we got to be evidence-based, but also we got to be clinically relevant, and the two have to move hand in hand. So that's what I'm going to try to do in today's presentation. And I'm going to start by being evidence-based before we start getting into the clinical perils for clinicians for day-to-day activities. So the problem with periimplantitis, the core issue that we have, is that there's no reliable treatment. Back in 2012, there was a big splash, a lot of publicity out of the first Cochrane systematic review on the topic that found that follow-up longer than 1 year after peri-implant regenerative surgery showed recurrence of periimplantitis in up to 100% of cases, right? Which literally translates into about 0% chances of resolution. So that was very, very negative. And now the next systematic review, 12 years later in 2024, found that actually with current approaches, we can only resolve disease in less than 50% of the cases. So within more than a decade, we haven't really progressed tremendously to the point where we would want to be with resolution of periimplantitis. And it's really fair to say that it's the most humbling procedure out of all those that we do in implant dentistry, because, we can place an implant in people that have, diabetes, that are smokers and whatnot. This can be very successful sinus lifts. Yet whenever we have a situation like this, there's a lot of clinical dilemmas, a lot of kitchen sink approaches, and a lot of inconclusive data on what we could do. So at least for the past years, we've started asking the right questions. And a couple of the right questions is, whenever I encounter this situation, that I have implants that have been now exposed to biofilm, have inflammation, have issues, why doesn't vertical bone augmentation work? How can I clean the implant surface effectively? Why don't antibiotics control peri-implant inflammation? And then ultimately, kind of the holy grail is titanium, a foreign body. And just to put into perspective how important periimplantitis is emerging as an issue in the entire field of implant dentistry, we've had two of the largest global consensus meetings that took place in 23 and 24 by the largest organizations, the AAP partnering with the AO for the first time, doing the 2024 consensus meeting on periimplantitis, and then the IADR, the best evidence consensus meeting in 2023. So some very important conclusions came out of those, and I'm just going to give you the heartbeat of these because the publications from both the proceedings just got published in the Journal of Periodontology this year, but a couple of the clinical perils were from the IADR BEC in 2023, abrasive titanium brush treatment use was associated with less peri-implant bone regeneration. So putting this into perspective, a procedure that we do, an adjunctive procedure that we do to better clean the implants, right, and get resolution of treatment, that actually results in less disease resolution, less regeneration. And then the second one, in 2024, the AAP and the AO came together, and one of the key conclusions was periimplantitis treatment should focus on biofilm removal from the implant surface, which is something we knew, while maintaining titanium surface integrity. And this is really something new and very exciting, and we'll see how it comes into play. And I think one of the main reasons of how we see that titanium surface integrity coming into play is exactly this. This is a case where I explanted the implant, as you can all see right here, implanted the premolar area. I'm explanted it, and this is all granulation tissue in the yellow box. I think that you can all see my mouse clicker pointing to the area, right? Yep. Okay. So within the yellow box, we have this accumulation, this aggregation of titanium particles that is visible with the naked eye. This is just the standard intraoral photo camera taking that photo, and you can see after excision of the granulation tissue, there's this visible debris, and to be able to actually see with the naked eye these particles that have diameter of about 10 micrometers, we now realize that we have quadrillions of titanium particles that have been released from the implant to the tissues. So that's very, very striking. And Tom Wilson was one of the first ones to look into this, and then Daniel Olmedo and myself also followed up and found in multiple studies that over 90% of periimplantitis cases are not due to bacteria alone, but over 90% of the cases are actually complicated by the presence of residual particles. These might be cement particles or these might be titanium particles, but they exist there. So what does that tell us? That tells us that periimplantitis is indeed complicated by these foreign bodies that we really don't know how to counter, because actual antimicrobial approach can really counter these issues. So as we move forward to that discussion, why is that important? And is titanium a foreign body? I think we have to pay attention to these cues that were kind of always there, but nobody ever paid attention to, because we were so used to periodontitis around teeth being a purely plaque-related disease. So you can see here, this is your run-of-the-mill peri-implant defect. And what you can note in this peri-implant defect is how circumferential it is around the implant, right? This is a perfect circle around the implant, and it's also self-contained to the point that there's a rim of bone separating the premolar tooth from the actual molar implant defect, which is very, very uncommon to see in actual periodontitis around teeth. Now, moving forward, this is not a singular occurrence, but you can see case after case after case, again, how well circumscribed the defect is around the implant and how vertically progressing rather than horizontal. So it doesn't progress to the adjacent teeth, it doesn't even progress to adjacent implants, but just is localized, and it's very rampant and very progressive. Now, is every implant case attributed to titanium particles or cement particles or some sort of foreign body? Absolutely not. And this is one example. I saw this case in San Antonio, and you can see here characteristic saucer type defect. And when I opened up the flap, I found a strand of floss. And you can see here that there's a little micro gap on the conic point. And as we clean the teeth, floss got cut. Patient had that floss cause really ligature-induced periimplantitis in that site. And that's what caused the problem. And this is kind of good news, because if I know what the problem is, if I know what the local factor is associated with that plaque-related disease, I can eliminate it. Another case showing you other things that are not really related to foreign bodies, but are other local factors, hard or soft tissue defects. Here you can see these threads of the implant showing through the peri-implant bone associated with deprobing depth. And this is a classic example of placing an immediate implant placement in the past without appropriate grafting, either in the form of socket preservation prior or grafting at the time of implant placement. And now we have resorption of the buccal plate. Implant threads are showing through. That's a hard tissue issue. That's not even periimplantitis at that point. So it's very important when we consider periimplantitis to really consider local factors that might lead to actual hard tissue, peri-implant hard tissue defects rather than true disease entity. And one prime example is limited keratinized tissue or very, very thin buccal plate, as in this case. But now going back to the actual periimplantitis and trying to start providing cues about how to treat that disease, this is probably one of the most seminal studies in the field that really shaped our thinking. It came out in 2017 from a group from Tel Aviv. And they found that whenever they were using ultrasonic scalers to clean implants, they were producing these titanium particles in massive numbers. So one simple cleaning occurrence with these ultrasonic devices that are very common to use around teeth, around the dental implants, caused about 1.5 to 3 million particles to be released. But these guys took it to the next level, and they took these particles and they injected them in the back of mice. And what you can see here is the actual lamellar bone pattern in the skeletal bone of the mice. And what you can see on the other hand side is the area where they've injected simply titanium particles. There's no implant there. They're just looking at the direct effect of the particles. And you can see this osteoclastic lacunae, or otherwise called osteoclastic resorption pits, throughout the bone. And they noted that not only they had massive bone loss happening just in result of particles, but when comparing particles with LPS, the effect of particles, the osteoclastic effect of particles was massive. So now we have kind of a direct causal link, if you may, between abrasion of the implant surface or lack of titanium surface integrity and inability to treat periimplantitis, which is very, very impactful for clinical day-to-day operations on how we maintain implants or how we actually regenerate implants. Now, this is a nice study, and everybody can keep note of this study. I'm going to give a QR code in the end where you can go to my website and you can download this study and all the other studies that I'm showing you in the full text if you want to delve more into it. This is a study by Alberto Monge and Homeley Wang and a lot of other famous people in the field, and I was included as well. And what we try to do here is summarize everything under the sun that has been ever attempted to treat periimplantitis. And you can see, for example, here, this is an SEM image on the very top, on the middle section, showing you the abrasion under the SEM, the apparent clinical damage that is caused whenever we use scalers to clean the implant surface. And we know absolutely that scalers should not be used to remove biofilm from the implant surface. They're not only ineffective, but they're going to destroy that implant surface, lose the titanium dioxide layer, and make it impossible for bone to regenerate on it. On the other hand side, now what becomes more interesting beyond the mechanical, where the abrasive effect is obvious, right? You get a metal scaler, you get an ultrasonic tip, you ablate that implant surface. But what's not as apparent is what happens when you use chemotherapeutic agents, like on the right-hand side. And you can see that a lot of different things have been used, anywhere from sterile saline, totally non-cytotoxic, to citric acid, hydrogen peroxide, or even concoctions like this, orthophosphoric acid. So there's case reports of people putting actual caustic orthophosphoric acid into periimplantitis defects. So we were compelled, based on those findings, to come up with a classification. And this is a good one to take a photo of this new classification that we published that really summarizes what can be used around implants into either mechanical or chemical means of cleaning the implant surface. And then within mechanical, we have contact or non-contact. And within the contact, it's very, very important to narrow down on abrasive versus non-abrasive. So you can see an example of abrasive would be the titanium brush. An example of non-abrasive would be a nylon brush or a micropolymer like the Cytosan microbrush. Now, on the chemical side, it's very interesting because we can use things that have non-selective cytotoxicity. One example would be chlorhexidine, and we're going to see in just a minute the ramifications of using chlorhexidine. Or we can use things that have selective or no cytotoxicity, and one example would be diluted sodium hypochlorite below the level where it's cytotoxic to our own cells, or sterile saline. So let's delve a little bit more into the effect of chlorhexidine. And because chlorhexidine was used early on in studies, and apparently each and every animal study that used animal models to look at peri-implant regeneration and use chlorhexidine reported horrendous results, absolute failures. So it became very interesting to us to start delving more into it and understand really why chlorhexidine has that effect. So we did this dog study where we placed implants in the mandibular premolar section of dogs. Then we did what is called ligature-induced periimplantitis, where you literally tie a ligature around these implants and you put it in and you allow plaque accumulation to happen. You see the profound inflammation here. And then you end up having this periimplantitis defects, which are similar in configuration to those in the human. So what we did was that we compared chlorhexidine to dilute sodium hypochlorite. And just an FYI, whenever you dilute sodium hypochlorite to about 1% or less, that sodium hypochlorite maintains the ability to kill bacteria, but doesn't kill bone stem cells anymore. Okay, so it's a very clinically useful concentration for situations like this. So long story short, we used on the left-hand side, sodium hypochlorite at 1%. In the middle, we used chlorhexidine. And at the edge, the right side, we used just sterile saline without any graft. Every other side got graft and membranes or whatnot for proper regeneration. So what we found was that 4 months after healing, 4 months post-regeneration, we really had modest results, about 1 millimeter reduction in probing depth, which was quite effective in sodium hypochlorite. We even got about 1 millimeter in median. You can see that here. This is the delta, the difference in probing depth. So 1 millimeter, about 1 millimeter median in the control, which means that sterile saline alone was able to reduce the probing depth in these cases. But then in the middle, when you look at chlorhexidine, the median is right at 0, meaning that in these cases, we were able to get no change in probing depth at all with chlorhexidine. And what was more interesting is that when we started looking into the histology, into the actual reosseointegration, we found that in the sodium hypochlorite group, which you can see on the right-hand side here, in some cases, we had absolute success, which means that we had new bone reattach all the way to the top of the implant, as you can see right here, or almost to the top of the implant. In some other cases, we had moderate, we had some bone gain, but not all the way to the top. And in some other cases, we really got stabilization of the bone with no bone gain. In chlorhexidine, in few cases, we had stabilization of the bone or very minimal bone gain. But in a lot of cases, we had absolute, actual downhill progression of disease. You can see here that this implant is barely hanging into the bone after use of the chlorhexidine. And over here on this particular one, you see something very interesting, that chlorhexidine, when it touches the implant surface, it creates an inhibition zone. So in this particular situation, the bone could not attach onto the implant surface because chlorhexidine has now coated that implant surface and has protracted cytotoxicity that kills the bone cells that try to latch onto the surface. So it was a very impactful study showing us that we were able to get significantly, nearly half the defect covered on average with the sodium hypochlorite treatment, but really no significant effect with chlorhexidine. So this study and others that we're not really going to have time to delve into today due to the limitations of our time, show that there's really 3 critical pillars of successful peri-implant regeneration. And these are: 1, preservation of surface cytocompatibility, which means that we really want to avoid coating the surface with either a chemical or abrading the surface with something mechanical that would make it less conducive to osteoblast attachment and regeneration. Number two, we want to enhance regenerative potential, which really happens with growth factor signaling. And merely osteoconductive grafts don't work well in these defects because the surface, once contaminated with biofilm, even if cleaned to perfection, right, in a non-abrasive fashion, and then we put bone graft to it, the defect is so large and the surface simply from biofilm contamination has reduced cytocompatibility. So we need something to enhance it. So we either need mixing some DFDBA that carries some BMPs in it with our FDBA, or we need to use autologous growth factors or exogenous growth factors, as we're going to see in a little bit. And last but not least, avoidance of iatrogenic toxicity. What does that mean? That means that we want to avoid abrading the implant surface to the point that the implant surface loses its integrity, loses its protective titanium dioxide layer, and starts leaking titanium particles into the tissues. And the implant is by no means a foreign body, but dental implants, titanium dental implants are extremely successful. But if we corrode them iatrogenically, if we abrade them and they start leaking titanium particles, these particles do act, not necessarily as foreign body, but do act as immune triggers that cause inflammatory cascades. So to put all this together, we did case studies where we were able to clean the implant surface with just purely sterile saline. And we saw remarkable results whenever we didn't abrade the implant at all and just reduced the biofilm with this simply with sterile saline and burnishing the implant surface. And as a matter of fact, the first ever study to show that reosseointegration is possible in humans by Paul Fletcher here from the East Coast used sterile saline and non-abrasive cleaning of the implant surface to accomplish that. So what he did in an implant that was, as you can see from the CBCT here, absolutely hopeless, he was able to clean the implant with sterile saline and some antiseptics, then graft the area, and then came back, explanted the implant, and histology showed you right here that absolutely beyond any doubt, there was new bone reattaching firmly onto the previously contaminated implant surface. So evidence of human reosseointegration being possible, okay, with just sterile saline and non-abrasive dental treatment. So in the last part of the presentation, where we're going to move into clinical guidelines now and clinical evidence, we were very interested to see if this theory that titanium abrasion might actually corrode the implant, if this theory is linked truly to adverse peri-implant outcomes in humans. So we did this study, and this study was thankfully funded by Osteogenics. So that was made possible, although we didn't directly compare the biomaterials. You guys were really nice in supporting science. And we asked the question, does abrasive implant surface treatment result in accelerated titanium release clinically? That was the main question. And then the second question was, does that lead to worse clinical outcomes? So here's an example, okay? This is your classic periimplantitis case, severe periimplantitis case, actually, 8 to 9 millimeter probing depths. This is the standard massive crater-like defect we talked about before. You see the rim of bone here protecting the adjacent tooth. And then we graft the area. I'll show you in a second with what we graft the area to enhance the osteoregenerative potential, place a membrane over, and close up. Now, in this particular study, we wanted to have a highly standardized way of treating every case. So every case got what we consider to be the gold standard for peri-implant regeneration, which was a combination of 70% nova bone morsels. And the reason is that these are defined by FDA as being osteostimulative, which is more than osteoconductive. And what really FDA determines as osteostimulation is the capacity of a biomaterial to attract bone cells, okay, bone pre-osteoblasts. So that's the reason why we use this to attract more bone pre-osteoblasts towards the implant surface. And then we use the collagen membrane, and we use 30% locally harvested autogenous with a micro-os in every case. And again, the autogenous comes in because we're bringing viable osteogenic cells to enhance the osteogenic potential. Now, I will disclose that initially we used the Cytoplast RTM collagen membrane. Now all our protocols have really switched to the Z matrix membrane. And the reason is because porcine peritoneum is so malleable, and you can see here on the pliers how the membrane actually conforms and has minimal memory. So that means that you can have great adaptation very quickly, and it doesn't have any memory, making it very, very easy to be retained exactly where you want it. So this is really a personal preference, because in periimplantitis, how long the membrane stays around doesn't really matter. But to me, application is really key in membrane selection. So that's just a personal preference. If you haven't tried porcine peritoneum membranes, I highly recommend that. So moving forward, this is the situation at baseline, and this is the situation of the 5-month follow-up, where you can see now that we started from an 8 to 9 millimeter probe in depth. We're now back to the 9 millimeter probe in depth 5 months later, after all this grafting was done, right? After all this cleaning of the implant was done. But the thing here that I have to tell you is that in this clinical trial, to assess the effect of abrasion, in half of the cases, and this is one of this half, where you use titanium scalers. So this surface was aggressively abraded with a titanium curette to get rid of the biofilm. So that being said, this is a pre-X-ray where you can see about 40% bone loss on the left side, and on the distal side, you can see about 60% bone loss. And this is the post side, where you can see that now we have about 60% and about 90% bone loss. And this is the subtractive radiography. Anything that is painted red in this automated superimposition is bone loss. So it's very important to spend, time is very valuable when you only have 45 minutes, but I want to spend a good minute here highlighting what that means. Because we put all this effort, we dropped in thousands of biomaterials. Patient had to pay approximately $3,000 for a treatment like this, right? Without sedation. And yet, within 5 months, we iatrogenically caused acceleration of disease progression to the point that it's now at the apex of the implant. So we must be doing something radically wrong. And because the other group, the non-abrasive group, got the exact same biomaterials, treated by the exact same clinicians, all parameters the same, but the intervention was, instead of titanium scalers, you use a non-abrasive nylon brush. And there we got on average 1.5 to 2 millimeters of bone gain of regeneration. So that provides direct cues to the fact that this damage to the implant surface might be the exact reason why we see this 100% relapse after a year, and why we also see study after study that has been published looking at antibiotics in periimplantitis, finding that antibiotics have no impact on treatment success at all, okay, at implants, which means that it's really not bacteria alone. It's the fact that if we abrade, if we damage the implant surface beyond repair, then it becomes impossible for that surface to sustain bone regeneration. And what I'm showing you here is we took it to the next level, and we assessed different cleaning devices. And you can see here, these are scanning electron microscope images of biofilms on the implant surface. This is on the left-hand side of the control. This is a very thick salivary biofilm on an implant under scanning electron microscopy, which means that we're now 100 times to 500 times magnification. And you can see with the titanium curette, what we do is selectively, where the curette touches that implant surface, we have abrasions, okay? We have scooping out of the defects. And then you see with a brush, this is a titanium brush, that wherever the brush touches the implant surface, we have streaks of removal where we actually have denudation of the titanium underneath. And at even higher magnification here, now we're going to 500 to 1,000 times magnification. You can see the classic honeycomb appearance here of a standard sandblasted acid-etched surface. And you can see the melting. You can see where the blue curette is, the melting of the surface that is caused by the curette. And that surface has lost its protective layer of titanium dioxide, and it's not able to sustain osseointegration anymore. And then on the right-hand side, you can see how the surface looks like if we use an absolutely non-abrasive, non-contact way of cleaning that implant surface with a water jet. Okay, so really, abrasive versus non-abrasive seems to be the largest differentiator in implant success. I kind of have a nice visual here to walk you through what we now think periimplantitis treatment failure causes are, and what we think that the right way to do things is. So as you open up your surgical flap, right, you have an implant with biofilm. Anything that is green is the biofilm. If you use a titanium curette, what happens is you only have partial removal of the biofilm. In reality, you remove just 25 to 30% of that biofilm. But as a consequence, as an adverse event of the use of the titanium curette, we have millions to billions of titanium particles released from the implant surface and continue to release because that implant is now damaged and will corrode in biological fluids. So the local cells are activated by these particles, and eventually we have osteoclastic activation. And as a result, we might have mitigated now the plaque-related bone loss, but now we have titanium-mediated inflammatory bone loss, very similar to the study that I showed you in the mice before. And as a result, we now see, despite treatment, recalcitrant cases where they keep coming back and progressing until implant is actually explanted. Versus in the non-abrasive treatment, you see here treatment with a water jet device, which is non-contact and non-abrasive, and it's really where we see the future headed with this. We remove the biofilm, and these devices achieve over 95% biofilm removal in a purely non-contact fashion. And you can see here the osteoblastic activation, because now bacteria are not there. We've reconditioned the implant surface, and we start having periimplantitis resolution. So this is truly a paradigm shift in how we deal, both on the level of implant maintenance now, because we want to avoid damage of the implant surface and harmful particle release, but also during surgical periimplantitis treatment. And here are the results of the trial, where you can see in the left-hand side, in the group that got the non-abrasive cleaning of the implant surface, the microbrush, this is the number of titanium particles that were released from the implant surface 2 months after treatment. We're not looking at the direct effect, but we're looking at how the implant surface is leaking titanium particles over time. And you can see that from the pre to the post, there's minimally any difference at all, versus at the group that got the abrasive treatment, the titanium curette. At baseline, this is how many titanium particles we had. At the follow-up, we had a massive number, 10 times greater titanium release 8 weeks after treatment, which means that the implant is now actively leaking constantly titanium particles. And on the other hand, we had about a millimeter gain after 6 months. And you can see here one example of cases treated non-abrasively, where you start from a moderate case of periimplantitis, and you can see the bone level here at 6 months all the way to the top again after appropriate biofilm removal non-abrasively. And by the way, non-abrasive instruments remove more biofilm than abrasive instruments. And on average, we have a millimeter bone gain, which ended up to be 1.5 to 2 millimeters at the 1 year. These are unpublished results, so I'm not showing you the 12-month data today. Versus what was more impressive is in the abrasive group, not only we didn't gain any bone, but in the majority of the cases, we actually lost bone to the point of 0.3 millimeters of bone loss after 6 months. So we now have a very clear guidance on the fact that abrasive treatment might actually be at the core of failure to treat periimplantitis. And I can show you case after case. This is another example. These are 2 implants with periimplantitis, again, randomized in the abrasive group. We treat them extensively to remove the biofilm. We graft with particles around it, 70% osteostimulated morsels, 30% locally harvested, micros harvested autogenous bone. And then you can see the result here very briefly. This is the 6-month re-entry, and look at what has happened, right? From the abrasion, we now have lost the buccal plate, defect has continued to progress, and at 6 months, that implant also needs to be explanted. Now, moving to the other hand, moving on to what do we do today? What have we learned from this? So this is a follow-up study we're now doing at Rutgers University. This is Dr. Rebecca Veith, one of our recently graduated residents, and Dr. Rihanna Sulaiki, the program director at Rutgers. So in collaboration, we continue with a new cohort on non-abrasive periimplantitis treatment, very similar protocols. And we have a few modifications to document how predictable success is. And I will tell you, the most important modification we did in collaboration with Tom Wilson, and we published this paper, we've developed the modified Wilson flap, which is exactly what you see right here. This is the original situation. This is the implant at baseline with moderate periimplantitis. You can see the x-ray right here. I'm showing you the x-ray. That's a take from the clinic. They were so excited when they got the patient for the follow-up that they took a screenshot of that implant before and after, and they sent it to me. So I just put it here to show you our enthusiasm for research at Rutgers. But this is the baseline condition. Right here, you see clear, moderate periimplantitis trough, and this is the clinical situation. You can also see lack of keratinized tissue. And then what you see right here, I'm going to show you an illustration a little bit, but we're doing a paramarginal internally beveled incision. What does that mean? That means is that we take our blade, we go about 0.5 millimeter away from the sulcus, okay? And with an internally beveled incision, we go down to the bottom of the defect. And the reason why we do that is because all the titanium particles that are abiotic, there's no way to remove titanium particles with antibiotics, right? Because they're not alive. They're trapped in that connective tissue, granulation tissue now, rather infiltrate around the implant. So we do that paramarginal incision, and then we follow with the secondary incision that is intrasulcular. So what that does is that it separates that strip of contaminated granulation tissue that's filled with the titanium particles, and then we're able to remove that strip of tissue that has the particles again, and this is what we're left with. Okay, so then we trace a regular full thickness flap, as you can see here. We access the periimplant defect, and now one of the most painstaking parts of periimplantitis treatment is to actually remove the granulation tissue. Now, by using the modified Wilson flap, we actually have already removed the entirety of the granulation tissue, and we can go ahead and graft. This is in FDBA with amelogenin, because as I said, again, we need growth factors to take it one step further. And this is a connective tissue graft taken at this particular situation to enhance the keratinized tissue in the area. And we close up, and this is the 6-month follow-up where you can see very, very promising periimplant bone regeneration. So again, just to demonstrate that flap, this is a very interesting technique. We have a paper that's going to be coming out in a couple of months regarding this. But what you see right here is that these titanium particles are invariably, in more than 90% of the cases, trapped within the connective tissue, the granulation tissue in the vicinity of the periimplant defect. You can see the periimplant defect here. So the first incision is a paramarginal, internally beveled incision to go to the bottom of the intrabony defect. And then the second incision is a sulcular incision. And what that does is that it contains this area right here that includes the granulation tissue and removes it en bloc. So moving forward now from the surgical, for the last part, we have about 10 minutes left. I want to cover a little bit what we do for maintenance. So for maintenance, in all our courses, whether it is for dentists or hygienists, we have the same approach, an implant-specific approach that I refer to as the implant safe protocol. If you want to download this PDF, you can just scan this QR code right here on your screen. That's going to take you to my social media with links to the website, and then the website includes this PDF and a lot of other resources for you. So feel free to take a photo of this right here. But the implant safe protocol essentially includes 4 distinct steps for implant tailored approach. And this can be used for implant maintenance. They can be used for treatment of periimplant mucositis and non-surgical periimplantitis treatment. And at the core of the protocol is probing the implant. There's no way possible to be able to prevent periimplantitis if we don't know when we have inflammation. And whenever we're able to diagnose early periimplantitis early on, it's much, much easier to resolve rather than actually moving to the stage of periimplant disease that is severe now, 50% or more of the implant, and we might consider explantation. So there's differences, very subtle differences that make a lot of clinical impact in periodontitis versus periimplantitis. So you see that in teeth, if you use an actual stainless steel probe, you have elasticity of the tissue, you have resilience of that epithelial seal, and there's not going to be rupture. We're not going to break the epithelial seal when probing. Around implants, you can see that this is a little bit different. And as a matter of fact, whenever we place the same amount of pressure that we place around a tooth, around an implant, we get much, much closer, about 0.5 millimeter near the bone. So in this particular case, my recommendation is for using implant-specific periodontal probes. This specific one, the ImplaSafe, is one that I designed actually in order to be made out of titanium and to be flexible and ultra thin, so that elasticity that doesn't exist in the tissues exists actually in the tip of that titanium probe. And then the second part, after we probe the sulcus and assess the status of the implant, that might be healthy, might have inflammation, mucositis, or might have actual disease, periimplantitis, right? We move forward to assess if there's calculus. And you'll see in this protocol, the only place where we use a curette is supragingival. It's only in step 1. So calculus is very rare to extremely rare in the threaded part of the implant, in the submucosal part of the implant, but it can be very common on the abutment level. For instance, you have a hybrid prosthesis, you remove it, you have tons of calculus on the abutment, but because of the electrochemistry of the micro rough or the nano rough implant surface, submucosally, there's just no calculus there. So the only area where we will use a curette, and if we use it, that's going to be a soft curette. Not every titanium curette is a soft curette, meaning that the Rockwell hardness of that curette is lesser than that of the implant surface. Okay, so we want to use a soft curette specifically at the implant abutment and never on the implant body, meaning underneath the gum line, because you can see here the massive damage that can be caused by these titanium scalars, abrasion, and really the initiation of iatrogenic corrosion of those implants. And then the next part is cement detection, which we're not going to have time to get into today. But the fourth part and last part is cleaning the implant surface. And across all regenerative studies in animals where reosseointegration has been shown to be possible, the gold standard is really shoe shining the implant surface, which means getting a gauze, cutting it, creating a strip, soaking that in either sterile saline or something with non-selective cytotoxicity like 1% sodium hypochlorite. And it's very, very important when you dilute that you're careful with the concentration to not over-provide, because you're going to kill the bone cells and release titanium from the implant surface. And then we burnish, we shoe shine the implant surface. Also, we can use non-abrasive and non-contact ways of cleaning the implant surface. And one that I'm particularly excited about is a water jet device that's actually completing the preclinical testing right now. And you can see here in this dog study that we did, we have both titanium and zirconia implants. This is calculus, as I was mentioning before, in the abutment level, not really on the implant level. And you can see the baseline biofilm right here. And you can see complete eradication of the biofilm after use of water jet irrigation in an absolutely non-abrasive fashion for just 60 seconds. So very excited about this treatment. This is how it looks like in reality. Sorry for the sound. And this is a clinical video. And this treatment really encompasses everything, because what it accomplishes is pressurized water provides ample pressure to detach the biofilm, because if you don't have calculus, biofilm is very easy to detach. You all know that you brush your teeth every night with a soft brush and you detach the biofilm. It doesn't take more than that. But the fact that we have a divergent water jet means we got great surface coverage. Glycine powder with air abrasion like an EMS could also be effective, but the problem with that is that if you use it under an open flap, you will get emphysemas, and they can be very, very substantial. So absolutely never recommend using air abrasion subgingivally with an implant surface. So this device is still not on the market, but I'm really hoping it's going to hit the market next year. We've done the preclinical testing for this. It's called the Bacturator. And I think that this is just one example of what's going to be coming into the market to be absolutely non-abrasive and to be implant specific at this point. And you see here how I envision we will have separate devices for implant maintenance. And you can see from our dog study here that we're showing absolute regeneration on those implant surfaces, both in titanium and zirconia, with non-abrasive implant treatment with simply sterile saline. And this is one example of the first case study that we did that you can see right here, the peri-implant defect. You can see the minuscule tip of the device being able to come into these tiny defects that you can't really fit anything. Clean the implant surface, not even touching it. You can see the implant surface after the cleaning here. And that's the clinical video. Yep, okay. I'm not going to attempt to show you the video again, just in case it's not buffering correctly. So I'm going to just go to the last slide and allow this time for our Q&A. But I welcome everyone to get a couple of information from this last slide. You can either use this QR code to go to social media and get a direct access to download all those things, or you can type in the URL for my website and download the PDFs and full text if you're interested about what we talked about. And here, I want to thank you guys at Osteogenics for supporting this, as well as supporting some of the courses we do. And one in particular that I'm excited about is the one with Dr. Ihab Musa at Yorba Linda. This is coming up fall this year, and this is a QR code for you all if you want to follow this and come and learn more. It's a comprehensive 2-day course going over soft and hard tissue grafting in periimplantitis and in detail all the protocols we talked about today. So without further ado, I think we can go into Q&A.
Oh, sorry. Fantastic. Thank you very much, Dr. Kotsakis. Appreciate the presentation. It was fantastic as always. And this subject is something that I know is very popular right now, and it's something that we're constantly learning more about. So appreciate your insight and all the research that you've done on it, and kind of leading the way in maybe changing the way we think about how to treat periimplantitis. So we got some good questions here. Try to get through as many of them as possible. And the first one, and there's a couple, I think you can answer both of them at the same time, but how come, can you kind of explain the fact that the titanium surface of implants, induces osteoblast, or at least it's, it can have osseointegration into it. But once there's titanium particles, we kind of get this opposite effect, and it induces osteoclastic activity. Can you just elaborate on why that is?
This is exactly what is happening, and this is exactly the problem. And Russ, it took us a decade to figure that out. So what happens if we put it into perspective, right? Let's talk about any type of surface. Let's talk about the Nobel surface, like the anodized surface. There's a trademark on that surface, and there's a patent on that surface, because what anodization does is that it creates a thicker titanium dioxide protective layer. So you get a titanium rod, you cut it, you create the threads, but then you have to process it. And anodization is a great way of thickening that titanium dioxide. You go to another company and they have a sandblasted and acid etched surface, right? So they have a proprietary technology to do that, because the acid etching will provide more surface area for more titanium dioxide. So it all comes down, when you think about big implant companies in the R&D, how can we make that surface more osteocompatible? How can we make that surface one that the bone cells will immediately jump on it? And we know that, right? When we started with the early Brandenburg times, you had to place an implant and wait 6 months to load it, right? Nowadays, you place an implant, you do immediate loading, or you place an implant and then you go back 6 weeks later, which is even more scary, do early loading, right? And it works. So we know that today's titanium surfaces are highly, highly cytocompatible. The problem becomes when this protective passivation layer, we call it titanium dioxide layer because it's more than 97% that, and there's some other monoxides on it and trioxides. But when that is for some reason removed, right? If I remove it right here in my room, on my desk, it's going to repassivate because I have oxygen in the atmosphere. If we remove that in the peri-implant pocket where we have an anaerobic environment and anaerobic bacteria exist, it's not going to oxidize effectively. It's not going to repassivate effectively. And what happens is we have interruptions. So that means that there's no protective coating on that titanium anymore. And it's like you compare, when you put the titanium, think about it like stainless steel. And when you abrade it, think about it as steel, right? So if you put steel in the human body, in saliva, what do you think is going to happen in a week? It's going to be all orange and crusty. So in titanium, that's very similar to what happens, and we see in reality, we see corrosion happening. So that's where the problem lies. It's the fact that we have now corrosion, so that implant surface is not osteoconductive anymore.
Good. Simple question here. How do you dilute the sodium hypochlorite to 1%? Is there a sodium hypochlorite to water ratio?
Yeah, what you can do is you can get, that's a great technical question. What you can do is you can get FDA approved sodium hypochlorite that we use in endodontic treatment. That's 5.25%. And you get 6 parts of that you get 1 part of that and 5 to 6 parts of sterile saline, depending on how much you want to dilute it. And then you mix them up in a little cup, and there you go. You got 1% or less.
Great. What's your thoughts on molecular iodine rinses? It's I guess company or someone claims that it's the best antimicrobial agent. This participant said they'd never heard of using this type of rinse until they were at a CE course last night.
Yeah. So I wasn't at that course last night, but I've heard about it before. What I'll say is that unfortunately for periimplantitis, you can't get something that works on periodontitis and move it over there, because in periimplantitis, it's the exact example of chlorhexidine that I showed you before. And what that means is that anything that goes into the implant, right, will get adsorbed with very strong bonds on the implant surface, especially if it's an organic molecule. So that means that if what I put there was a little bit cytotoxic, I'll be okay. If what I put there is very cytotoxic, like chlorhexidine, then I'm going to have a problem, because it's going to keep killing the bone cells that try to latch. So with iodine, iodine is very cytotoxic. I don't know about molecular iodine because I don't think anybody has done the research. So that's one of those things that unless we have the research behind it on implant surfaces in periimplantitis, I'm really not going to add it to my protocol, because we run the risk with implants. Anything you put can actually make things deteriorate.
Chip. Can you talk about just any experience with ceramic or zirconia implants compared to titanium as far as the occurrence increasing or decreasing of periimplantitis?
Yeah, well, zirconia implants are scary because if we don't know how to clean titanium implants once, we don't know how to clean zirconia implants, twice. The reason is, if you use anything abrasive, right? If you use a burr, if you use scalers, if you use anything like that, and you cause one microfracture on that zirconia, sometime they're going to chew on something and it's gone, right? It's going to fracture. So they're very brittle. That's what makes non-abrasive cleaning even more important. Now, there's studies out there that clearly show that zirconia abutments collect less plaque, like I have less plaque accumulation than titanium. So that means that clinically in humans, we probably will have a slower rate of occurrence for periimplantitis, although we don't have these studies available. This is just, deducting logically. But what I will tell you is, in the study I showed you before, we did in San Antonio with titanium versus zirconia implants, and we did ligature-induced periimplantitis. They both got disease. So no doubt you can get periimplantitis zirconia implants. The good news is, in our study, we showed that we can successfully regenerate both zirconia and titanium using non-abrasive treatment.
We have several questions here about lasers. So how did laser treatment compare to your proposed treatment? How do lasers factor in for soft tissue ablation? And then can you speak about your thoughts on the LAPIP and a NDYAG? So lasers.
Yeah. The ND-YAG in general, it's been conceptually promising. But LAPIP is one of the things that I'm not going to use. And the reason why I'm not going to use it is not because it doesn't work. The reason why I'm not going to use it is because we don't know that it works. So you have to go through all this process, right, to ablate the tissue around it. And there's not a properly done randomized clinical trial showing that it works. And as a scientist, whenever I see something that's based on case studies, I got to be very skeptical, because I showed you a case study before just using Bernstein with sterile saline on periimplantitis and impeccable results. And I can provide 10 more cases of those and show you impeccable results. That doesn't mean it's the best way forward or the only way forward, because what if I did it 500 times and I had 10 successful ones and I show you those, right? So because the ND-YAG is so promising, but at the same time, it's so expensive, right? And it comes to a cost to the clinician, a cost to the patient. This is where we need to invest in randomized clinical trials. So I think we should not accept things that have a low level of evidence before we get the randomized trials. I pray that ND-YAG is a good solution. I just don't know, because we really need better solutions. But I will say that in terms of lasers, if you have a nervium YAG laser, this is the only laser that can actually work on removing biofilm from the implant surface effectively. Okay, so this is one you can use directly on the implant surface as compared to the ND YAG for soft tissue.
What about the galvosurge? We have two different questions. Just thoughts around galvosurge. What's the thought process there?
Galvosurge is conceptually brilliant because it's purely non-abrasive, absolutely non-contact, non-abrasive way. Preliminary data, preclinical data show that there's some efficacy, conceptually brilliant, very aligned with non-abrasive treatment. The regulatory trouble, the fact that it's not approved yet, makes me wonder whether, we're going to have it sometime soon available, at least in the United States. I know it's available in Canada. I know from the Canadian folks that they're also a little bit concerned because it's quite expensive to use it. Like, it's more expensive than your bone graft and membrane together. So I think if we move in the same direction, I don't know if it's going to be galvosurge that make the difference, or maybe the Bacterator that I showed you before, if it becomes first FDA approved. But if we move into that direction of non-abrasive in the most simple and effective to implement way, then we will have a really good solution for periimplantitis.
Just we'll wrap it up with a couple simple questions here. But first one is, and Intellex, the Bacterator is available. Could a water pick at its highest level work to remove biofilm?
So this is interesting. I've used water pick for periimplant mucositis clinically. You have to use it at the lowest level. It's still effective, but you're not going to take a shower for both you and your patient. And if you use it, don't say that I told you, because one, it's off label, and two, you have to have a really high speed vacuum on the other side. Make sure it takes the water, because the volume of water it puts out, it's just a ton. But yeah, if you're able to put it in for non-surgical periimplant mucositis, would work.
Non-abrasive instruments. They might be on the QR code, but can you just generally point people in the direction of where they can get the non-abrasive instruments that you like to use?
Yeah, absolutely. They're in the QR code. It's a kit that I developed in collaboration with Salvin. So it's called the Impla Safe Kit, and it's available by Salvin if you're in the US.
Okay, great. I think we'll wrap it up there. We actually got through the majority of the questions. Well, actually, there's a second page here, but we're a little bit out of time. So anyhow, we will wrap it up there. Dr. Kotsakis, thank you so much again for your time tonight. I know it's getting late there on the East Coast, and we appreciate you sharing with us and teaching us tonight. And we look forward to doing other things together. I want to make sure everybody's aware. Dr. Kotsakis showed it, but in early October, him and Dr. Ehab Musa are doing a course out in California focused on periimplantitis. That should be something that's really exciting. So you can get more information on Dr. Kotsakis' website about that. Also, just for everybody, remember, we'll be sending out a survey shortly after we get offline here. Once you fill out that survey, you'll get your CE certificate. So just some logistics there. But with that, thanks again, George. Very good to see you, and hope to see you soon in person.
It's always a pleasure. Have a great night, and thanks everybody for joining.
All right. Thanks.